You're somewhere in your third trimester, maybe lying in bed, maybe grocery shopping, maybe just going about your day, and suddenly, something feels wet. Your heart rate spikes. You freeze. You think, is this it? Did my water just break? Maybe you've watched the movies. Maybe you've seen the scene 100 times. The big gush, the dramatic gasp, the race to the hospital. But let me tell you right now, the movies got it wrong. At least most of the time. Real water breaking? It can be a gush. But it can also be a trickle. A slow leak. A dampness you can't quite explain. A pop you heard but barely felt. And a shocking number of moms, first time and experienced alike, are genuinely unsure whether their water broke or they just near sigh. Leaked a little pee. It's okay. I promise you're not alone. Today, I'm going to cover everything you need to know about your water breaking. What it is, what it feels like, what it looks and smells like, how to tell it apart from discharge and urine, what to do the moment it happens, and the warning signs that mean you need to get to the hospital immediately. By the end of this video, you will feel prepared. You will feel confident. And when the moment actually comes, you'll know exactly what to do. Let's start at the very beginning. Section 2. What is amniotic fluid and why does it matter? Before we get into the signs, you need to understand what amniotic fluid actually is, because once you know its purpose, you'll understand why it matters so much when it leaks. What is amniotic fluid? Amniotic fluid is the liquid that surrounds your baby inside your uterus throughout your pregnancy. It fills what's called the amniotic sac, a double-layered membrane that encases your baby from just a few weeks after conception, all the way to birth. In early pregnancy, this fluid is primarily made up of water from your own body. But as your baby develops, typically around the second trimester, something amazing happens. Your baby begins to swallow the fluid, process it through their kidneys, and urinate it back out. Yes, your baby is essentially peeing in their own environment, and that is completely normal and healthy. What does amniotic fluid do? Amniotic fluid is not just filler. It is a critical, life-sustaining substance that serves multiple important functions. Cushioning and protection. It acts as a shock absorber, protecting your baby from external bumps, falls, and pressure. If you trip or bump your belly, the fluid helps distribute that impact, so it doesn't reach your baby. Lung development. Your baby actually breathes amniotic fluid in and out of their lungs throughout pregnancy. This motion is essential for developing the lung tissue and muscles your baby will need to breathe air after birth. Temperature regulation. It helps maintain a stable, warm temperature around the baby, protecting them from temperature fluctuations. Muscle and skeletal development. The fluid gives your baby room to move, kick, and stretch, and that movement is essential for healthy muscle and bone development. Umbilical cord protection. It keeps the umbilical cord from being compressed, ensuring a continuous flow of oxygen and nutrients. Infection prevention. The fluid contains antibodies that help protect your baby from infection. How much fluid is there? Amniotic fluid levels peak around 34 to 36 weeks of pregnancy at approximately 800 milliliters to 1 liter. That's roughly the size of a large water bottle. After that, levels begin to taper slightly as you approach your due date. If levels are too low, it's called oligohydramnios. Too high is called polyhydramnios. Both conditions are monitored by your care provider during routine ultrasounds. Section 3. The anatomy of the amniotic sac. So, we know what amniotic fluid does, but what actually is the amniotic sac and why does it break? The 2 layers. The amniotic sac, and often called the bag of waters, is made up of 2 distinct membrane layers. The amnion, this is the inner layer, thin and transparent, that's in direct contact with the amniotic fluid and your baby. The chorion, this is the thicker outer layer that lies against the uterine wall. Together, these 2 layers form a remarkably strong and flexible container. Throughout pregnancy, this sac is designed to stretch, flex, and protect. But as labor approaches, hormonal changes, physical pressure, and the natural progression of your pregnancy cause the membranes to weaken and eventually rupture. Why does the sac break? There are several reasons the membranes might rupture. Natural labor progression. As contractions build and your cervix dilates, the pressure on the lower part of the sac increases until it gives way. Artificial rupture. Your provider may manually break your water during labor using a small hooked instrument called an amnio hook. This is called artificial rupture of membranes, or SROM, and is a routine, low-risk procedure. Pre-labor rupture. In some cases, the membranes rupture before labor begins on its own. More on this in a moment. Infection or inflammation. In rarer cases, an infection of the membranes, chorioamnionitis, can weaken the sac and cause early rupture. Where does the sac break? This is crucial and often misunderstood. The sac does not always rupture at the very bottom, near your cervix. It can rupture anywhere along its surface. A rupture near the bottom tends to cause that dramatic gush of fluid people associate with water breaking. A rupture higher up, toward the top or sides of the sac, creates what's called a high leak. In a high leak, fluid slowly seeps down and out, which is why some women experience a slow, steady trickle rather than a sudden flood. This is why so many women are unsure whether their water has broken. A high leak can feel very subtle, almost like you're slightly wet, but can't figure out why. Section 4. All the signs your water has broken. All right, this is the heart of today's video. I'm going to walk you through every possible sign that your amniotic sac has ruptured. Some of these will be obvious. Some will surprise you. Sign number 1, the dramatic gush. Yes, this one is real. Some women do experience an unmistakable, sudden, uncontrollable gush of warm fluid that soaks through underwear, pants, bedding, or whatever they're wearing at the time. This typically happens when the sac ruptures at or near the cervix, creating a large opening that allows fluid to rush out quickly. It can happen while you're standing, lying down, or mid-stride at the grocery store. If this happens to you, don't panic. The gush may last only a few seconds, but fluid will continue to trickle out afterward because the sac can no longer reseal. Put on a pad immediately, not a tampon, and call your provider. Sign number 2, a slow, steady trickle. This is actually far more common than the gush, and it's what catches many moms off guard. You might notice you're just wet, persistently wet. You go to the bathroom, wipe, think you're fine, and then you feel it again. A slow trickle that keeps coming back no matter what you do. This is the classic presentation of a high leak, a small rupture higher on the sac. Because the tear is small and positioned away from the cervix, fluid drips slowly and continuously rather than rushing out. The key distinction here, you cannot stop it. No matter how hard you try to clench, the fluid keeps coming. This is what sets it apart from normal discharge. Signs are 3, a popping or snapping sensation. Some women, not all, but some, describe feeling or hearing a distinct internal pop just before their water breaks. It's subtle, almost like a small balloon deflating somewhere deep inside your pelvis. If you experience this sensation, pay close attention to what follows. Even if the fluid release is minimal, that pop is a meaningful signal that the membranes may have ruptured. Sign number 4, sudden pressure relief. Many women describe a sensation of sudden pressure relief in their lower abdomen or pelvis just after their water breaks. If you've been feeling a heavy, tight, or full sensation in your lower belly, and that sensation suddenly eases, it may coincide with your membranes rupturing. This isn't a standalone sign, but paired with wetness or a pop, it's worth noting. Sign number 5, constant wetness. That returns. One of the most reliable indicators of water breaking is the persistence of the wetness. Unlike sweating, discharge, or even occasional urine leaks, amniotic fluid keeps replenishing itself because your baby's kidneys continue producing it even after the sac ruptures. So, if you feel wet, change your underwear and find yourself wet again within minutes or hours. That cycle of wetness is a significant clue. Sign number 6, wetness. During movement or position change, gravity plays a role. You may notice more fluid when you stand up from lying down, when you walk, when you shift positions, or when you cough or sneeze. This is because movement changes the pressure dynamics inside the uterus and allows more fluid to seep through the tear. If you notice a pattern, more wetness when you move, less when you're still, this is actually a helpful sign pointing toward amniotic fluid rather than urinary leakage. Sign number 7, labor contractions follow shortly after. In many cases, when the amniotic sac ruptures, labor contractions begin within a few hours, sometimes sooner, sometimes a bit longer. If you experience a fluid release and then start feeling regular, rhythmic cramping or tightening in your abdomen within the next 12 to 24 hours, that's your body confirming what you suspected. However, and this is important, do not wait for contractions to confirm your water broke. Call your provider as soon as you suspect your membranes have ruptured, regardless of whether contractions have started. Sign number 8, a feeling of something changed. Softer tone, validating maternal instinct. This one is harder to quantify, but don't dismiss it. Many experienced mothers describe just knowing something shifted, a felt sense that their body crossed a threshold, an instinct that something significant just happened, even if they couldn't articulate it medically. Trust that instinct. Always call your provider if something feels off. That's exactly what they're there for. Section 5. What does the fluid look, smell, and feel like? Okay, let's get into the details, because one of the most confusing things about water breaking is figuring out what the fluid actually is. So let's break it down by sense. What does it look like? Normal amniotic fluid is typically clear to pale yellow in color, similar to water or very dilute urine. Sometimes slightly cloudy or milky. This is normal, and often due to vernix, the white waxy coating that protects your baby's skin. May contain small white flecks. This is also vernix and is completely normal. May have a very faint pinkish tinge, especially if your cervix has been dilating and there's been some light spotting. This is normal. Red flag. If the fluid is green, brown, or dark yellow, especially if it has a thick or murky appearance, go to the hospital immediately. This may indicate the presence of meconium, your baby's first bowel movement, in the amniotic fluid. Meconium-stained fluid can be a sign of fetal distress and requires prompt medical evaluation. Red flag. If the fluid is bright red or contains significant amounts of blood, call emergency services or go to the emergency room immediately. What does it smell like? This is one of the most useful distinguishing characteristics, and yet almost no one talks about it. Amniotic fluid has a distinctive smell that is often described as slightly sweet, almost like diluted honey or mild syrup, earthy or musky. Some describe it as similar to semen or a natural, slightly organic scent. Neutral or barely noticeable. Some women say it has almost no smell at all. What it does not smell like is ammonia. Urine has that sharp, unmistakable ammonia tang. If whatever you're smelling is clearly ammonia-scented, it's much more likely to be urine. Pro tip, if you're unsure, put a pad on for 30 to 60 minutes. Then smell it. Amniotic fluid will have that sweet or neutral scent. Urine will smell like urine. What does it feel like? Temperature. Amniotic fluid is warm. It's been maintained at your core body temperature, around 37 degrees, 98.6 degrees, throughout your pregnancy. So the fluid will feel warm, not cold. Texture. It feels watery and thin, not thick or sticky like discharge. It flows freely and doesn't leave a thick residue. Quantity. The amount can vary enormously. Some women lose most of their fluid in one gush. Others have a high leak that only releases small amounts over time. Section 6. Water breaking versus urine versus discharge. Let's tackle the most common question I get. How do I know it's my water and not just pee? First, there is absolutely no shame in this question. In late pregnancy, your bladder is being crushed by a 6 or 8 pound baby. Leaking urine when you sneeze, cough, or laugh is incredibly common. You are not alone, and the two can genuinely feel similar. So let's differentiate them properly. Amniotic fluid versus urine. Color. Urine is yellow, anywhere from pale yellow to a deeper amber depending on your hydration. Amniotic fluid is clear to pale white, cloudy. Smell. Urine smells like ammonia. Amniotic fluid smells sweet or neutral. Control. This is the most reliable test. Stand up, try to urinate if you can, then clench your pelvic floor as tightly as possible. If the fluid stops completely, it was likely urine. If fluid continues, even as you clench, it is likely amniotic fluid, which cannot be voluntarily stopped. Pattern. Urinary leakage typically happens in isolated moments. A cough, a sneeze, a sudden movement. Amniotic fluid tends to flow continuously in varying amounts. Recurrence, change your underwear. If amniotic fluid is leaking, you'll be wet again shortly. Urine typically doesn't continue unless you're physically straining. Amniotic fluid versus vaginal discharge. In late pregnancy, vaginal discharge increases significantly. You may notice more white or yellowish discharge on your underwear throughout the day. Here's how to tell it apart. Consistency. Discharge is thick, mucus-like, and sticky. Amniotic fluid is thin and watery. Volume. Discharge appears in small amounts. Amniotic fluid flows more freely. The mucus plug. In the days or weeks before labor, you may lose your mucus plug, a thick, jelly-like discharge that may be clear, white, pink, or tinged with blood. This is different from amniotic fluid. Losing your mucus plug does not mean your water has broken. It simply means your cervix is beginning to prepare for labor. The at-home test. If you're genuinely unsure, you can try this simple test at home while waiting to hear from your provider. 1. Empty your bladder completely. Doubt. Put on a clean, dry pad or panty liner. 3. Lie down for 20-30 minutes, then stand up. 4. Check the pad. Is it wet? What does the fluid look and smell like? 5. If you see clear, sweet-smelling fluid, call your provider. There are also over-the-counter amnio detection products, like Amnio Sense or Amnio Check Pads, that change color in the presence of amniotic fluid. These are reasonably reliable, but always follow up with your provider regardless of the result. At the hospital or clinic, your provider can confirm membrane rupture using a nitrazine paper test, which checks the pH of the fluid. Amniotic fluid is more alkaline than urine, or a ferning test. Dried amniotic fluid creates a fern-like pattern under a microscope. Both are quick and definitive. Section 7. High leaks versus full rupture. One of the reasons water breaking feels so different from woman to woman is that not all ruptures are equal. Let's talk about the two main types. Full rupture of membranes. This is when the sac tears at or near the cervix, the lowest point of the uterus. Because gravity is working with the leak and the opening is positioned optimally, fluid rushes out readily. This is what causes the dramatic gush most people associate with water breaking. After a full rupture, fluid continues to leak consistently because your baby's kidneys keep producing it. You may soak through multiple pads in a short period. High leak, high rupture. A high leak occurs when the tear is higher up on the amniotic sac, further from the cervix. Because the opening is not at the lowest point, fluid doesn't drain as readily. Instead, it slowly seeps down and leaks out in smaller amounts over time. High leaks are particularly easy to miss or misidentify. The fluid release can be so subtle that it's easy to dismiss as normal discharge, sweat, or mild urinary leakage. But the key, again, is that it doesn't stop. If you keep noticing unexplained wetness over hours or a day, even small amounts, call your provider. It's always better to be checked and sent home than to wait and risk complications. The ongoing fluid myth. Many women worry, if my water broke and all the fluid drained out, won't my baby be in danger? Here's the reassurance. Amniotic fluid is continuously replenished. Even after a rupture, your baby's kidneys keep producing urine, which maintains some level of fluid. The danger lies not in the fluid draining, but in the increased risk of infection once the protective barrier of the sac is compromised. This is why timing matters. Your provider will want to know when rupture occurred and will monitor for signs of infection. Section 8. Pre-labor versus in-labor rupture. PROM and SROM. SROM. Spontaneous rupture of membranes. SROM is when the amniotic sac ruptures on its own during active labor. This is the most common scenario. Labor is already underway, contractions are progressing, and the rupture of the membranes is simply part of the natural labor process. In SROM, the rupture often accelerates labor by allowing the baby's head to press directly against the cervix, increasing dilation and intensifying contractions. PROM, pre-labor rupture of membranes. PROM stands for pre-labor rupture of membranes. This is when the sac ruptures before labor has begun. It affects roughly 8 to 10% of pregnancies at term. Most women with PROM go into labor naturally, within 12-24 hours, without any intervention. If labor doesn't begin on its own, your provider may recommend induction to reduce the risk of infection. PROM, preterm, pre-labor rupture of membranes. PROM is when the membranes rupture before 37 weeks of pregnancy. This is a more serious situation because it increases the risk of preterm birth and infection. PROM affects approximately 3% of pregnancies and requires immediate medical evaluation. If you are before 37 weeks and suspect your water has broken, do not wait. Go to the hospital or call emergency services immediately. Section 9. When to be alarmed. Warning signs. Most of the time, water breaking, even before labor, is a safe and manageable event. But there are specific signs that require immediate medical attention. Do not wait. Do not call and ask if you should come in. Just go. Go to the hospital immediately if the fluid is green, brown, or dark yellow, possible meconium, indicating the baby may be in distress. The fluid contains bright red blood or heavy bleeding. You can feel or see the umbilical cord. This is called cord prolapse and is a medical emergency requiring immediate intervention. You are less than 37 weeks pregnant. Preterm. PROM requires emergency evaluation. You have a fever over 38 degrees, 100.4 degrees. This may indicate chorioamnionitis, an infection of the membranes. Your baby's movements have noticeably decreased since your water broke. You feel sharp, constant pain rather than rhythmic contractions. This could indicate placental abruption. You feel faint, dizzy, or unusually unwell. Cord prolapse deserves special emphasis. If you feel the umbilical cord between your legs or see it protruding from your vagina, get on your hands and knees immediately. Call emergency services and stay in that position until help arrives. This is rare but extremely serious. The cord being compressed by the baby's head cuts off oxygen supply. Section 10. Step by step. What to do when your water breaks. Okay, your water just broke. Or you think it did? Here's exactly what to do, step by step. Step 1. Don't panic. I know this is easier said than done, but take a breath. Unless you're experiencing the emergency warning signs I just mentioned, you almost certainly have time. Very few women deliver within minutes of their water breaking. The average time from water breaking to active delivery can be several hours. Step 2. Note the time. Write down the exact time you noticed the fluid. Your provider will ask. It matters because the longer the membranes are ruptured without delivery, the higher the infection risk. Your provider will use this information to make decisions about your care. Step 3. Assess the fluid. Before you do anything else, take note of color: clear, yellow, pink, green, brown. Smell: sweet, neutral, or ammonia-scented. Amount: a gush, a trickle, or just dampness. Consistency: watery and thin, or thick and mucus-like. This information helps your provider assess what's happening and make initial decisions over the phone. Step 4. Put on a pad. Place a clean maternity pad or thick sanitary pad in your underwear, not a tampon. Tampons are never appropriate once your membranes have ruptured because they can introduce bacteria into the vaginal canal and increase infection risk. The pad helps you monitor ongoing fluid loss and will be useful to show your provider if needed. Step 5. Call your provider. Call your OB, midwife, or birthing center immediately, even in the middle of the night. This is not an inconvenience. This is exactly what their on-call system is for. Tell them, when you notice the fluid, what it looked and smelled like, how much fluid there was, whether you're having any contractions, whether your baby is moving normally. They will guide you on whether to come in immediately or wait for contractions to begin. Step 6. Avoid baths, swimming, and sexual activity. Once your membranes have ruptured, the protective barrier between your baby and the outside world is gone. Avoid immersing yourself in water, including baths and swimming pools, as this can introduce bacteria. Also, avoid sexual intercourse for the same reason. Showers are fine. Step 7. Head to the hospital when directed. Your provider will tell you when to come in. In most cases, if you're at term, 37 weeks or beyond, they'll want to see you within a few hours, regardless of whether contractions have started. If contractions are regular and progressing, go immediately. Pack your hospital bag, wake your partner, and try to stay calm. You've prepared for this. You're ready. Section 11. What happens at the hospital? When you arrive at the hospital or birthing center, here's what to expect. Triage assessment. You'll be checked in and assessed by a nurse or midwife. They'll take your vitals, check your baby's heart rate, and ask about your symptoms. Fluid confirmation test. If there's any uncertainty about whether your membranes have ruptured, they'll perform a nitrazine paper test, checks fluid pH, or Ferning test. They may also do a pooling test, placing a speculum to visualize whether fluid is pooling in the vaginal vault. Cervical exam. They may perform an internal exam to check cervical dilation and effacement. Fetal monitoring. Your baby will be placed on a continuous or intermittent monitor to check their heart rate and ensure they're responding well. Decision point. Based on your gestational age, cervical status, fluid appearance, and whether contractions have begun, your provider will develop a plan, which may include waiting for natural labor to begin, starting oxytocin, pitocin, to induce contractions or other interventions as needed. Try not to be alarmed by the activity level. This is all routine monitoring to ensure both you and your baby are safe. Section 12. Myths Debunked, plus reassurance. Mantra myth number 1. Your water always breaks with a big gush. Busted. As we've covered extensively, the slow trickle, the high leak, the small pop, these are all valid presentations of membrane rupture. Don't dismiss your instinct just because there was no dramatic splash. Myth number 2. Labor always starts right away? Busted. Most women go into labor within 24 hours of their water breaking, but it's not instantaneous. Some women wait several hours before contractions begin. Your provider will guide you on what to do in the meantime. Myth number 3. Once your water breaks, you must deliver within hours or the baby will die. Busted, mostly. There is a time-sensitive element because of infection risk, but with proper medical monitoring, most women have a safe window of 12-24 hours after rupture before delivery. Your provider will monitor you closely for signs of infection, fever, fetal heart rate changes, unusual discharge. Myth number 4. If you're not in pain, your water didn't break. Busted. Water breaking before labor begins, PROM, often happens without any contractions or pain whatsoever. Fluid release alone is not always accompanied by discomfort. Myth number 5. You'll always know immediately. Busted. High leaks in particular can be so subtle that women genuinely don't realize what's happened for hours. That's okay. That's normal. If you suspect it, call and ask. If today's video helped you, please give it a thumbs up. It genuinely helps more mamas find this content when they need it most. Subscribe for weekly videos on labor, delivery, postpartum, and new motherhood. And drop your question, your story, or your water-breaking moment in the comments. I read every single one. I'll see you in the next video. You've got this, mama.